Hello, my name is Yejun Hong. I'm a medical student in the University of Calgary, and our team is here to explain retinopathy of prematurity as a link between ophthalmology and pediatrics. The eye overall is made up of countless parts, complex anatomy, and many different layers. So it is a complex organ that takes a lot of time to develop. The eye as an organ fully forms by week 26 out of 40 of pregnancy, but angiogenesis for the retinal vasculature needs to continue developing its intricate network up until 36 to 40 weeks until delivery. Therefore, retinopathy can develop in instances of prematurity, and is closely associated with low birth weight, preterm delivery, and oxygen administration through iatrogenic means. So, retinopathy of prematurity, or ROP, is an abnormal retinal vasculature development due to the shortage of adequate developmental period for angiogenesis, and this is usually a diagnosis in neonatal stage. Let's take a look at the forward-facing view of the retina. There are a lot of different vessels, including the retinal veins and arteries, and they all sprout out from the optic disc. The optic disc is at the nasal portion of the retina, and at the temporal side we can see the fovea and the surrounding macula. This is where the visual information for your central vision is collected. In terms of pathophysiology, while the structure of the eye is complete in its growth by week 26, angiogenesis of the retina starts by 16 weeks at around the optic disc. This pans out peripherally to all the hypoxic regions of the retina through VEGF stimulation. However, this does not finish developing until after delivery. Then while nasal retina, which is close from the optic disc, is fully vascularized, temporal retina is not yet developed by delivery. So even at 36 to 40 weeks, the temporal artery has not been fully vascularized. So when the delivery is preterm, you can see you may expect that the retinal vasculature is even less complete. The premature delivery with complications requires special attention from the hospital. Supplementally, oxygen therapy may be applied to keep the baby breathing and to prevent peripheral cyanosis. However, this oxygen supplementation increases the available oxygen to the retina. While this sounds at first an advantage for the eyes, it is not in the case of development. The ideal partial pressure of oxygen for retinal vasculature growth is 25 to 35% because the stimulus for vasculature growth is hypoxia. The body needs to sense that the vasculature needs to grow and the tissue needs to be better supplied with oxygen. But with iatrogenic means, if the retina already gets enough oxygen, there's no need for vasculature to fully develop. As we talked about, VEGF promotes the growth of new vessels and responds to a hypoxic state. IGF-1 is another hormone that permits the action of the VEGF. Low level of this hormone means that VEGF may not be as effective in its role. So although there's a hypoxic state in the retina and there's a lot of VEGF. If there's low IGF, the VEGF will not be able to exert its full effects to angiogenesis. IGF-1 is delivered through the placenta, so after delivery, the IGF-1 level is bound to be low. So premature delivery with supplemental oxygen means there is less VEGF and there's less IGF-1 because there's no more connection with the placenta. The risk factors to developing ROP is if the birth is premature, especially with less than 33 weeks of gestational age. If the baby is low in birth weight, ROP can occur more frequently. Supplemental oxygen therapy, as we covered, prevents the release of VEGF for proper angiogenesis. Complicated hospitalization can lead to oxygen therapy, and prematurity, even less than 36 weeks, can begin to have an effect. There is an international criterion for ROP divided into 5 stages. In stage 1, there's a white, flat demarcation line between the posterior vascularized retina and peripheral, non-vascularized retina. Then in stage 2, the line becomes elevated and forms a pink-white ridge. In stage 3, there's a fibrovascular proliferation from the said bridge. That can be extraretinal. In stage 4, there's subtotal tractional retinal detachment, and in stage 5, a total retinal detachment occurs. For adequate treatment of ROP, there are different zones that we need to be aware of within the retina. Zone 1 is demarcated by red areas in the picture on the right. This is the inner zone that encompasses the optic disc and up to 60 degrees from the optic disc. This is an area equivalent to a circle with a radius that's twice the distance from the disc to the macula. Zone 2 is the area between zone 1 and the circle centered on the optic disc and tangent to the nasal ora serrata. And lastly, the zone 3 is all of the remaining temporal area of the retina, and it's identified as the green area. When well managed, symptoms of retinopathy of prematurity can be asymptomatic. Signs of ROP may include shallow anterior chamber, corneal edema, and iris atrophy. Pupils can be impaired in its dilation, and there may be posterior synechia present between the lens and the iris. Ectropia on UVA is the presence of iris pigment epithelium on the anterior surface of the iris. And you can see that on the top right picture. And ROP can also have, in severe cases, vitreous hemorrhage, and in stages 4 and 5, retinal detachment. One complication of ROP includes the plus disease, which is at least 2 quadrants of shunted blood. This causes an vascular engorgement in the posterior pole with tortuous arteries, as demonstrated in that picture, and dilated veins. Vitreous haze and pupillary rigidity can be present simply because of the stiffening of the iris due to vascular engorgement. Coates disease, Eales disease, familial exudative vitreoretinopathy can present with similar constellations of signs. And these are some of the other diagnoses that must be ruled out before settling on retinopathy of prematurity. Because the majority of the ROP is detected at the neonatal stage of life, it will be important to screen all preterm infants that are less than 1,500 grams at birth or less than 30 weeks gestational age for ROP presentation at the retina. And it's also important to gather ophthalmic history, specifically family history of ocular disease or conditions, and take note of any hospital procedures that are related to the eye of the newborn or to oxygen supplementation of the neonate. Obtain birth history and birth weight, and cycloplegic refraction may be warranted because many can develop refractive errors later on and require glasses. Last note when making diagnosis is that ROP is a clinical diagnosis. You take the history and observe the back of the infant's eyes and recognize the ridge and stage the ROP. There is no definitive factor in lab work and investigations to diagnose ROP. For type 1 ROP, ablation of peripheral avascular retina can be helpful. Indirect argon green or diode laser photocoagulation with a spot size of 500 micrometers and applying the laser to the entire avascular retina in zone 1 and peripheral zone 2 is indicated in laser ROP study, and cryotherapy to entire avascular retina in zone 2 but not to the ridge is indicated according to cryo-ROP study. For later stages of ROP where tractional or rhegmatogenous retinal detachment is observed, vitreoretinal surgery with pars plana vitrectomy, membrane peel, or sclerobuckle is indicated. Follow very closely every 1 to 2 weeks until extreme periphery has been vascularized. Then we can space it apart to every month. Rush disease is plus disease. Remember that's a complication of ROP in zone 1 or posterior zone 2. This is the reason for the very close follow-up because things can get bad very quickly. So AP-ROP, which is a disease with risk of rapid progression to stage 5 within a few days, can occur in instances of rush disease. Intravitreal anti-VEGF agents with bevacizumab can be effective according to the BEAT-ROP study conclusion. The prognosis of this disease depends on the amount and staging of ROP, and 80 to 90% fortunately will spontaneously regress. However, in stage 5 where there is total traction retinal detachment, there is poor prognosis, and later on the child may develop myopia, glaucoma, cataracts, keratoconus or abnormal shape of the cornea, van keratopathy, as well as retinal detachment later on. Here is again the link between ophthalmology and pediatrics. Here's a summary slide of everything we talked about in this presentation. And here's a reference of all the information we've gathered for this presentation. Thank you for watching this video.